Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to our distinguished guests, honorable speakers, and valued participants. Welcome back everyone to the annual 7th Emergency Seminar Series webinar. We've now reached our third week, and today's theme focuses on land envenomation and poisoning. My name is Liana, and I will be your moderator for today. So this seminar series is proudly organized by Universiti Kebangsaan Malaysia, Universitas Brawijaya, and also University of Philippines, co-organized by Toxinology Education Resources and Development in collaboration with Wilderness and Austere Medicine Society, Malaysian Society on Toxinology, Remote Envenoming Consultancy Services, Pusat Racun Negara, and Malaysia Biodiversity Information System. On that note, we would like to express our utmost gratitude to our line of sponsors with whom generous support have helped make this webinar possible. And they are J.A. Nabila and Co. Advocates and Solicitors, Wilderness and Austere Medicine Society, Remote Envenoming Consultancy Services, Malaysian Society on Toxinology, and last but not least, Pusat Racun Negara. Your generous contributions are truly invaluable and are greatly appreciated. So the flow of today's seminar will be as follows. So we will have 3 lecture sessions in the morning, followed by, after the lectures, we will hold an interactive Q&A session, followed by a Kahoot session at the end of the seminar. So a few housekeeping reminders before we begin. If you have any questions during the lecture, please post them in the Q&A box. Your questions will be answered during the forum Q&A session later. So all lecture slides will not be shared. However, recordings of the session will be made available, and you can find the link for the last 2 recordings for the last 2 sessions in the chat box as well. As for the winner of the Kahoot session later, please do contact us via the email address that we will provide in the chat box as well. And finally, for attendance, a QR code will be shared on the screen at the end of this event. So kindly scan them and fill up the form for attendance. Okay, so without further delay, let us begin this week's seminar by welcoming our first speaker for today, Dr. Chew Kim Hoon. A little bit of background about Dr. Chew. He is an emergency physician and trainee in the clinical toxicology subspecialty program and currently serving at the emergency and trauma department of the Sarawak General Hospital. He has an extensive background in emergency medicine with over a decade of experience in managing a wide spectrum of critical cases, including poisoning and envenomation. So he has served as both organizing committee member and speaker for the basic and advanced toxicology courses, as well as a speaker for several toxicology CME sessions organized both at state and national levels. So with that, please join me in welcoming Dr. Chew Kim Hoon, who will be sharing his insights today on the topic of snake bite when the knife is sheathed.
So, hi, good morning, everyone. Thank you for inviting me for this webinar. So my topic today will be snake bite when the knife stays sheathed. So I will start with a case discussion first. It's a real case that I seen in Sarawak, then followed by the discussion about this topic. So this is the case that I seen here. It's a 32-year-old gentleman. He was bitten by a snake over the right elbow at around 5 in the evening, then presented to our emergency department around 6 p.m., which is 1 hour later. Then on arrival, he was triaged to yellow zone initially, then he described it as a black color snake. But just after half an hour, we noticed that he has a left eye ptosis. Then, so he was just pushed to resus. Then prepared to give the antivenom. So, but while preparing venom, the patient started to have symptoms of respiratory paralysis. So he started to have difficult breathing. So we have to proceed with intubation and subsequently complete the administration of the antivenom. So this is the picture that we able to take before the patient was intubated. You can see the left eye ptosis with the and the bite mark over here over the elbow region. So this is the next morning. The patient was admitted to ICU around midnight. So the next morning in the ICU, the ICU team referred to orthopedic team for assessment for compartment syndrome, KIV for fasciotomy, because they noted the patient hand. This is on arrival, the patient hand is already very swollen. Then, so and the orthopedic team assess the patient. They feel that there is a very tense swelling from the elbow down to the right hand, and they're unable to feel the radial pulse properly over the right hand. CRT is around 2 seconds for both hands. So the orthopedic surgeon was decide for fasciotomy of the right hand and the right forearm. So before that, then the medical team was seeing the patient also. Then they just called me out to ask whether the surgery is necessary or not. So at this point of time, because the patient is intubated, so the clinical assessment sometimes a bit difficult because after snake bite, the swelling can be very severe and very firm. So we use the ultrasound. We assess both the radial artery and the brachial artery, but too bad. Sorry, I only have a picture of the radial artery one because initially I didn't expect this case to be presented anywhere. So I only got this picture. So there's an absence of DRAF, means that the target artery is not compressed. So subsequently, I discussed with the orthopedic team and NS team, so they agreed not to proceed with fasciotomy, continue to monitor first. So the patient was successfully extubated on day 3 of admission. There are only some small blister formed over the forearm, and the content was aspirated. Same for CNS, there is no growth seen. So the patient was not started or anything, and subsequently the swelling reduced. There is no dermal necrosis. The patient was discharged well after 5 days of admission with subsequent KK follow-up to assess the hand and forearm swelling. But otherwise, the patient did not require any surgical intervention and successfully treated and go back home. So the dilemma here is whether the fasciotomy is needed or not. So it's whether to cut or not to cut. So just a bit of introduction. The envenomation syndrome in Malaysia are complex, but mainly the length net of significance we divide to 2 classes, is the Elapidae and Viperidae. Elapidae, Naja species is one of the most serious species in the family Elapidae. It can cause both neurotoxicity and also local tissue necrosis, and frequently requires surgical intervention. Viperidae family include our pit viper, typically cause profound local effect as well, but there is also the systemic effect is mainly the blood clotting system, disruption of blood clotting system. So first to the Naja species, the venoms of Naja species. In Malaysia, we only have a Naja cauda and Naja sumatrana. So averaged in 2 classes of toxin, which explain the envenomation syndrome. Is the alpha neurotoxin and also the cytotoxin. The alpha neurotoxin will act at the postsynaptic neuromuscular junction, so it causes the progressive descending flaccid paralysis. The cytotoxin is the one responsible for the cytotoxicity, which causes the local tissue damage. Mainly manifests as dermal necrosis, blistering, and extensive swelling. And sometimes it can occur in the absence of systemic neurotoxicity. And if there's a dermal necrosis, the resulting necrotic tissue is actually a good breeding ground for secondary bacterial infection. So most of the time, if there is a blistering and signs of infection, we may need antibiotic afterward, but not prophylactically. For Viper, there are also local effect and systemic effect. The local effect is progressive swelling as well. It may involve entire limb, also cause blistering and some necrosis sometimes. For systemic effect, it's mainly coagulopathy. It can manifest as either platelet with thrombocytopenia, reducing platelet, coagulopathy like prolonged INR, and some tests previously we did the 20-minute cold blood clotting test. It may be positive is prolonged. So for the systemic envenomation is quite clear cut, and we know that the antivenom is needed. And for the local effect, especially sometimes we need the antivenom, but the problem arises when we need to decide whether the patient require any surgical intervention or not. So the most serious local effect is the compartment syndrome. It's very rare in snake bite incident to cause a compartment syndrome. But if it happen also, it will happen just like our usual traumatic cause of compartment syndrome. But there are 2 main points to consider in the cases of snake bite related swelling. First, the snake envenomation usually cause superficial edema because of the fang mark. They usually bite locally and cause superficial edema, and there's increased subcutaneous tissue pressure rather than the intra-compartment and the intramuscular compartment pressure elevation. But because of the superficial edema, very significant swelling, sometimes it can mimic the through compartment syndrome. And in addition, the myonecrosis due to snake bite is because of the action of the venom. In the through compartment syndrome, the necrosis, muscle necrosis is due to increased intracompartment pressure, causing reduced blood flow and subsequently causing necrosis. But in snake bite, most of the time is because of the action of venom. So the pathophysiology is different. That's why the management is different as well. And the management will be mainly by anti-venom because the necrosis is due to the action of venom. So the management is mainly anti-venom rather than surgical intervention. And the animal study has shown that anti-venom can help to reduce intracompartmental pressure as well. So this is in our WHO guideline for the management of snake bite second edition. The criteria for fasciotomy in snake bite related acute compartment syndrome is the hemostatic hemolysis must be corrected first with anti-venom with or without clotting factors. Then there is a clinical evidence of intracompartmental syndrome. And the gold standard is the measurement of intracompartment pressure more than 40 millimeter mercury in adults. In children, is different because their limb size, everything is different. There is no specific cutoff for the kids, but for adults, we take 40 millimeter mercury. So before even the intracompartment pressure is more than 40, but the first thing is the anti-venom must be given first. Especially in viper bite, there is hemostatic abnormalities, it must be corrected. If not, we go for intervention, it will cause more bleeding, more harm to the patient. So this is the device that used to measure the intracompartment pressure. I don't think there's not many hospital got this equipment. My hospital don't have it. That's why most of the compartment syndrome is by clinical assessment in the trauma cases. So since we don't have this device, so nowadays everyone can use ultrasound. So now we can actually use the ultrasound to assess the patient. It is not definitive, but at least it can help to suggest or give you a clue that whether the patient is in more likely to have through compartment or is just significant swelling without the compartment syndrome. So the role of POCUS in snake bite is nowadays POCUS is very popular and getting more and more important, not only in snake bite, in every field in our emergency setting. Now, even in the ward also, everyone is using this for the medical team in ICU. So in snake bite, it can visualize the extent of the subcutaneous edema, appear like the cobblestone pattern. This is similar to what we see in cellulitis, the cobblestone pattern. If any one of you want to look for it, you can try on your cellulitis patient. The cobblestone light is similar to the snake bite swelling also because it's all in the subcutaneous layer, subcutaneous swelling. So this is one of the more precise measurement of the RPP, our rate of proximal progression. We always ask for, in snake bite, we always ask for RPP monitoring, but sometimes everyone's eyes is different. So if one person see the rate of progression, he might put the marking at different area compared to another person because it's very subjective. But with POCUS, we can definitely know that the swelling is up to which point. So later, this is like what the example here. You can see the got pointer. So this cutoff point, this is the bone. This is the cobblestone-like feature in the subcutaneous layer. So this is a subcutaneous edema. And over here, it becomes the normal subcutaneous layer. So this point is the exact point that the swelling is up to this area. So 1 hour later, we use the ultrasound again. If we extend, we just slowly slide the probe, then we can measure the RPP accurately. So there's a prospective study on bites from the pit viper. This species is actually the Taiwanese habu. This study is by the Taiwan, and you can search the study online. It's also the post protocol with Prof. Khaldun, the Taiwanese toxicologist, together with Prof. Khaldun, come up with this role of POCUS in snake bite. So the clinician used the deceleration of the RPP measured by the POCUS at the endpoint to guide the antivenom therapy. And they found that this can help to reduce the number of vials of antivenom use. So we try to save cost, cost-wise already safe, and we didn't do any extra harm to the patient. And with less antivenom, also there is less risk of complication from the antivenom, like the allergy, hypersensitivity reaction, serum illness, etc. The second indication, it can help to prevent unnecessary surgery. So the severe swelling from the envenomation, as mentioned, is often mistaken for compartment syndrome. So the misdiagnosis is a major clinical risk because unnecessary surgery can cause more harm, especially if the snake bite is a pit viper bite. It associated with coagulopathy, then it become more catastrophic because it cause more bleeding and it's more difficult to treat subsequently. So the King Cobra study that published by Racun in Malaysia also noted cases where premature fasciotomy can associated with very serious outcome, like infection, unnecessary bleeding, and the patient had prolonged stay even up to few weeks, 2 months, just to manage the wound site because of the surgery. So POCUS can help to differentiate through compartment syndrome from the snake bite related swelling only. So how to differentiate is mainly by using the pulse Doppler signal of the target artery. We measure the DIF. So this is the feature that show that positive findings in the radial artery. So just use the pulse wave Doppler, then we can see the systolic wave and the diastolic wave. This diastolic wave is retrograde. So the DIF, the R is the retrograde, diastolic retrograde. So this is the retrograde wave compared to this patient one, which is there's no retrograde. It's all straight line below. The systolic is the peak, the diastolic is the small peak here. So this is the normal waveform. But if it is a positive true compartment syndrome, we will see the systolic wave as such, but the diastolic is become a retrograde flow. So in this patient, although clinically it looks very suspicious for the compartment syndrome, but the DIF is negative. There is no retrograde flow of the diastolic wave. So the compartment syndrome is unlikely, and in fact, the patient really don't have the compartment syndrome and avoid the surgery. So how about the management of suspected compartment syndrome in snake bite? The first line is still antivenom, as mentioned. The first line is always the antivenom. We try to reduce the action of venom first. And the published series from Southeast Asia, mostly by Thailand and some of our Malaysia study also, are actually more common in viper bite rather than the cobra bite. We'll explain later a bit more. There's not much study, but somehow we found that viper bite is more commonly associated with compartment syndrome compared to cobra, but the incidents are still very rare. So this is a retrospective review of Malayan pit viper bite published by Thailand, reported to the Poison Center in Thailand, Ramati body. It showed that necrosis and compartment syndrome is one of the complications, but they take the 167 patient, local complication including compartment syndrome, it was diagnosed in 12 patients, necrotizing fasciitis in 5 patients. And so it showed that Malayan pit viper is around 7%, so we can take it like around 10%, but this is pit viper. So another study also by Thailand, also they test the Malayan pit viper. Malayan pit viper can be found in northern part of Semenanjung. So those in Kedah, Kelantan area, usually if you have a pit viper bite, then you have to take note that it can be Malayan pit viper also. Is the antivenom is different from the green pit viper because the species is different. It's not Trimeresurus, it's a Calloselasma. So in this retrospective study, there are 800 patients. Only 4% were reported to have impending compartment syndrome. They put impending, but they didn't specify what is the reason they put as such, whether it is clinical or it is direct measurement, or they use because they didn't specify it. But in the article, they put an impending compartment syndrome, but none of them underwent fasciotomy. All were successfully treated with antivenom. So after antivenom, the swelling reduced, everything reduced, and the patient didn't require any surgical intervention. So next, we go to, since the case is cobra, so just now I mentioned that viper bite is more common to have compartment compared to cobra. So how about cobra? Cobra bite. So this is a study published by, also retrospective, by the Thailand side. There are 500 patients bitten by cobra. 200 out of 40% underwent surgical intervention, but most of them are actually wound debridement because of the tissue necrosis. So 90% underwent the wound debridement. 4% after the wound debridement requiring skin graft, and some patient unfortunately require amputation. Only one patient underwent fasciotomy. The next is the Nada species is in Malaysia, just recently published this year. The surgical intervention was conducted in 10% of the cases. As similar to Thailand study, 90% underwent wound debridement. Only one underwent fasciotomy also in this data. So the fasciotomy, the true compartment syndrome in cobra bite is much less compared to viper bite. So in short, in Southeast Asia, viper bites have a higher true compartment syndrome risk compared to cobra bites. The reason being that the viper is hemotoxic, as mentioned, also has cytotoxic and myotoxic. So it can cause a massive edema, bleeding inside the tissue intracompartmentally, and the swelling will cause elevation of compartment pressure. So we know the cause is because of the bleeding into the tissue. That's why the first line management is the antivenom before we decide for surgical intervention. And reported more often in Russell viper and Malayan pea viper bite. For the cobra, the venom is, as mentioned, is neurotoxic, cytotoxic. So it's actually a superficial edema. So it appears like it's very tense swelling, but inside the muscle compartment, the pressure actually is not high because it's mainly at the subcutaneous and the skin layer. It can cause tissue necrosis, it's the dermal necrosis. As the name implies, it's actually just the skin part. It's not deep into the muscle. So it just mimics the compartment syndrome. And most of the time, if we have the direct measurement, it will be below the surgical threshold, which is a 40 millimole mercury. So the mainstay of management is still the antivenom first before we decide for any surgical intervention. So the take-home message, the true compartment syndrome is rare after snake bite. And if it happens, it's higher incidence in viper bite compared to cobra bite. Clinical painful swelling is not equivalent to compartment syndrome in snake bite cases compared to our surgical compartment syndrome in trauma cases. Is because of different pathophysiology. The pain, tenseness, and edema alone are poorly predictive. The gold standard is still pressure measurement. POCUS can help to facilitate the clinical decision. And if we need to manage, always antivenom first. Fasciotomy is often unnecessary. It increases the risk of bleeding, infection, and necrosis post-surgical, post-fasciotomy. So most of the time we try to avoid it and can monitor first and try to give appropriate dose of antivenom before we really decide for surgical intervention. So that's all, thank you. So if cannot bring back anything, first just need that the clinical swelling in snake bite demands antivenom, not the knife. Thank you.
Thank you so much, Dr. Chu, for the enlightening lecture. We will see you back again during our forum Q&A session later. So as for the participants, if you have any questions, please type them out in the chat box below and we will have them answered during the forum later. So without further ado, we're moving on to our next lecture. It is my pleasure to introduce Dr. Harry Sutanto, an internal medicine physician at Dr. Saiful Anwar Regional General Hospital Malang, and specializes in tropical and infectious diseases. Dr. Harry completed his subspecialty training in Brawijaya University, where he also earned his internal medicine specialist qualification. He also currently serves as the chairman of the Antimicrobial Resistance Control Committee and chairman of the sepsis team at his institution. So let us welcome Dr. Harry Sutanto to share his insights on our next topic, snake bite, a clinical conundrum. Dr. Harry?
Thank you. Good morning, everyone. Would like to present our slide. I'm sorry, I didn't get my slide presentation. Can see our presentation, please? Okay, good morning, everyone. Today I'll be presenting an artist that capture the reality snapshot as clinical control in Indonesia. The condition put the ancient and neglected yet still claim life and limbs our communities. And our disclosure, this is the no conflict of interest to the disclosure, and this patient had admitted in the Saiful Anwar Hospital in this Malang. And the first, what is the conundrum in our slide? On paper, snake bed management seems simple. We can identify the snake, give the antivenom, and support the patient. But in the reality, in the surface, the three layers of challenge. The first is the clinical conundrum. We often don't know what hit the patient. And the second, the systemic conundrum. Our antivenom supply doesn't match our biodiversity. And for the data conundrum, we don't ever know how big the problem truly is, but the patient usually came in our hospital is most quite usual in this patient. And at 2017, the WHO has recognized the snackbed and Envenomation has the neglected tropical disease. Is praised on the poor of farmer, plantation worker, and fisher. That exactly like our patient today, the Indonesia and as a home for the 77 medically significant snack beds sits across the Wales line. So the geographical divide to the west and the east that make the antivenom for the west is different from the east. There's the robust national advocacy for the snake bed with the many victim never reach the hospital, relying the traditional healers using the leaf or the treatment in the traditional healers. So sometimes the patient came to our hospital with the wound and the lead condition. And usually in our evaluation of the EMS, we use the code as animal bed or toxic effect, not the snake bed for the case of the snake bed. So the morbidity and mortality in our region is usually is not truly knows in here. Okay, Indonesia has the less of the extreme biodiversity. We can see in here the richest word in the herpetofauna, and we have the major families concept in the snake. The LAPDA, they usually the patient the condition is neurotoxic. The Viperidae, usually the hemotoxic and cytotoxic, and Colubridae are growing the consent, that and Celtic and others. And we have the Wallace line, critical geographical barrier, and we have two area in here, west and east. In the west, ASEAN fauna, we have the Najas putatic, the Calostema rhodostoma, and Bunga species. In the east, Papua and Maluku, with the Australian fauna, we have the Aquarius suppletus and Acanthopus species. With the clinical implication, antivenom in the west is 100% useless in the east area. The common clinical challenge before patient came to our hospital for the patient side, the using of under first of evaluation and treatment is using the sometimes that make the harmful of the condition, using the tourniquet, incision, suction, using the some others of the traditional medicine is the normal in the area, but it's not the exception in the treatment. And for the treatment intervals, the patient delayed in frustration, maybe from the more than 1 day and others. From the clinical side, usually the story for this patient or the anamnesis for the patient, the snake is almost never identified, just only the black one, didn't recognize the kind of this snake because the usually patient get it get the bite in the night or on the the place that we can see the snake very clearly. So using the syndromic approach, we force to treat the base of the symptoms which we might be delayed for the condition. Okay, we choose the first at the one that is the initial context why, and we prepare for the case report. The patient in this presentation is 70 years old farmer from female in the East Java with the comorbid uncontrolled hypertension. This is the population that usually can get the snake bite in our area. Patient came with the pain in the local left foot, and nausea and vomiting. At the first came in our hospital, a patient only 1.5 hours after being bitten, but the patient get some systemic symptoms. The hypoxemia, the saturation was 70%, hypertensive urgency 180/118, and tachycardia. Oxygen was administered, and we can evaluate the two fang marks were present along the edema extending up to the tourniquet. We can see in here that the mark of the tourniquet before when arrived in our ER, we cut the tourniquet, so we can still see the mark of tourniquet here. There is no systemic Envenomation were initially formed. From the laboratory imaging, we showed the leukocytosis 12,000 and negative or normal in others evaluation. X-rays reveal the bronchopneumonia and cardiomegaly. We use the initial management with the immobilization, IV normal saline, and giving the antihypertension and symptomatic relief. And after 24 hours observation, there is a local sign appeared in this patient. The purplish black bully on the right foot, accompanied with the pain and fever, and leukocytosis worsening in the next day from the 12,000 to the 60,000. We give the intervention with the aspiration of bully, and we local wound care with the sulfadiazine and giving antibiotic for this patient. After 40 hours, the bully the patient general clinical condition improved. The leukocyte begin decrease in the 40,000. Patient discharged after 4 days in this hospital with the wound is didn't any increase or make bigger. But after 1 week, patient came into the hospital with reporting the wound become worsening. You can see the bully has progressed into the ulcer with necrotic tissue, and debridement was performed in the outpatient clinic and giving the oral antibiotic for this patient, and the patient came to the outpatient department. Nah, in this evaluation, the patient giving better the wound, and after the 1 month, the wound will refill, and we can see the lack of the public knowledge in here using the tourniquet and others, giving the symptoms that the patient very unclear in here. And family applied the inappropriate tightly bone group tourniquet in the first one, and the specific of the snack didn't any declare in here. We didn't give no anti-venom in here. And after evaluation of the bully and the wound, we can see the extensive necrosis, high risk in irreversible effect, including in the amputation and deformity. So after giving the good evaluation of the wound, we can get the patient in the outpatient department. And the final evaluation, the patient clinical consent given a measure of level, the hospital observation and wound care, and early department once necrosis occurred. The worsening in the home, we can see in the evaluation of the 1 week, and the case at least we need to provide detailed education for patient and family member regarding the first evaluation for the wound, and following the department perform the clinic, and patient will improve, and outpatient was avoided, and the local Envenomation this one. Rehabilitation is essential, not the evaluation of the systemic treatment for this patient. Now, what happened for this patient? The bite from the untreated snake is likely cytotoxic, and the first treatment is harmful, like solitary tourniquet is used in this patient, and delayed evolution of local sign. This must be confronted information, and we give the correct decision without antivenom because no systemic sign in this patient. The socioeconomic factor force the premature discharge. So in the severe and preventable mortality, we evaluate the necrosis and risk of infection about in the wound. Nah, why we didn't give antivenom in this patient? Each country, Indonesia has only available product that we split in our country. We use the sabu, the biosafe. It's trivalent but incomplete. It covers some Western species, but none of the Eastern region. Even for common snake like green pits or the crate can use the cross neutralization before the available important polyvalent antivenom are rare and prohibited expensive in this country. The problem is the purity problem. The clinician afraid using some impurities of the formulation of sabu. The high rate of pyrogenic before severe hypersensitivity in our country is usually happen. So we are very careful to using the sabu in our country. If there is no any sign of symptom systemic antispecial, we didn't use the giving the systemic anti venom in this patient. The physical in the rural setting using the antivenom as much as the venom. So the fear of the venom and the fear of the antivenom is the same. They become hesitant at administer even when indicated. It's this the poor outcome and the blame the snack bed, not the lack of the treatment. In the west area, the coverage of case sabu is from the medicament of the state is actually is correct. We can cover the green pit fiber, blue grade, and russell fiber. King Cobra and red hazes is the west area. In the east, sabu, biosafe, zero coverage for many common annual snake. In the east, usually we use the sabu or biosafe imported from the Australian region to cover the sabu in the how to we solving the conundrum? We embrace the syndromic approach. We must stop worrying about the species and treat the syndrome. The first, if the neurotoxic, actually we can get the ptosis, paralysis, and nerve failure. We make the action secure airway ventilated and give antivenom sabu immediately. The second syndrome is hematotoxic. We can see in the coagulopathy, bleeding, and there's we have the evaluation of laboratory finding and give the antivenom, prepare the blood products to reduce the bleeding in the patient. And the third is the local cytotoxic, the swelling, bully, and necrosis. In our case, antivenom is not the priority. We use the limb elevation, the antibiotics, and early debridement in this patient. From the local wound management, the aggressive in our case is the probability to decrease the morbidity when mortality is not imminent. The goal is to the limb, and the key intervention is the aseptic aspiration of the tendon, giving the antibiotic secondary infection and early antibiotic treatment of all necrosing tissue and potential need for skin grafting if the wound is very extensive. And the most clinical intervention is break the harmful pre-hospital care. We must influence our community or our patient do not to give the tourniquet, incision, section, blackstone, herbal remedies or others, and do immobilization and go to the hospital immediately. And from our presentation, the conclusion in SNACPED in Indonesia is a deep and complex clinical conundrum, but is not unsolvable and is the social conundrum rooted by poverty and geography. The systemic conundrum highlight major gaps with our data, tools, and training. The solving it requires to look beyond the individual patient and fix the system that fails them the treatment. Thank you for our time, and I give it back to the.
Thank you, Dr. Harry, for the insightful lecture. We will see you again during our forum later. Again, for the participants, if you have any questions, please type them out in the chat box below and we will have them answered during the forum later. Welcome back, everyone. I hope you've had a good break. So before we resume our next lecture, I would like to direct your attention to the chat box. where you can find the links for the recording of the previous 2 sessions. And we've also shared a link of the latest pediatric protocol regarding snake bite injury in children. You can find them in the chat box. Okay, so with that, let's continue our last lecture of the week. Dr. Ruchel, let's welcome Dr. Ruchel A. Simene. Dr. Ruchel A. Simene is a physician whose expertise in toxicology and poison management has made significant impact both locally and internationally. He currently serves as the head of the Northern Mindanao Medical Center Toxicology Center and a consultant at the National Poison Management and Control Center, two major institutions central to the management of poisoning and envenomation cases in the Philippines. He completed his fellowship in clinical and occupational toxicology at UPPGH and has led and participated in numerous training programs and international conferences on toxicology, hazardous materials, and chemical incident management. So with his wealth of experience in clinical toxicology and poison management system, I believe he will bring an insightful perspective to our next topic on snake pit viper. Without further ado, I welcome you, Dr. Ruchela.
Good morning, everyone. So thank you for inviting me to speak here online on the, I think it's a 7th EMS conference. So can you hear me? Just raise your hand if you don't hear me. So my topic is about a viper bite. So I will just share my experience about managing viper bites here in Northern Medical Center, Philippines. So it is located in the southern part of the Philippines. So my objective is to present a case of a 43-year-old male beaten by a viper snake who received aggressive intervention but with an eventful outcome, to discuss the sequelae of pit viper envenomation in the absence of anti-venom, and to briefly compare the outcome of the other pit viper bite cases with different approach and clinical management. So it's only a disclaimer that the most of the slides and materials used in this presentation were originally prepared by Dr. Josephine Haraba, a graduating family medicine resident. I acknowledge her authorship and contribution to the development of this case presentation. The use of her materials is solely for educational purposes with due credit to the original author. But I can give you the PDF copy of this slide. So it is 12.37 per 100 incident of snake bite, and the 0.51 per 100,000 there is a reported mortality. In region 10, here in our region, so we have a case that is most commonly young males. Wait, it's most commonly in Bukidnon, where the is usually in the lower extremity. So this is a 43-year-old male patient with a chief complaint of gipa ako sa halas, or in English, snake bite. It is about 13 hours prior to admission. Patient claimed that there was a yellow-green snake that bit the left leg. It was seen that it was diamond-shaped head. Then there was a 2 fangs, and it was 3 feet long. So the bitten area is bleeding, and patient immediately felt numbness. There was no loss of consciousness, difficulty of breathing, blurring of vision, nausea, vomiting, and chest pain. So the patient immediately placed a tourniquet, a red shirt. So patient was then brought to their home. At 4 hours prior to admission, there was persistent bleeding and severe pain with a pain score of 10/10. There was also abdominal pain and headache. Hence, the relatives and the family members decided to bring the patient to the hospital. So the hospital in Bukidnon. It is a mountainous area. Just gave omeprazole, hydrocortisone, and tramadol, and then it was then called to our institution and was transferred. In our institution, the physical exam revealed a bleeding wound. There was also a different scratches in the right leg, and the ecchymosis in the mid aspect of the thigh, and then there was a clearly two punctured wound which begin to have a hematoma and ecchymosis also. So it was scored by the examining physician at the ER using the WHO scoring system that the envenomation was a moderate in severity. So the diagnosis was then toxic effect of snake bite, pit viper likely with moderate signs of envenomation. So at the ER, since the patient complained of pain, and then there is bleeding, slow continuous bleeding, then the motor strength is 4/5 in the lower extremities. So because of there is spontaneous bleeding, we considered about venom-induced consumptive coagulopathy. But then we suspected of viper, but then the history of asking about the color of the snake and what's the shape of the head was not yet extracted at that time. That's why the toxicologist, since there is weakness in the lower extremity, and also patient is also perceived to be weak, we gave a cobra anti-venom, because in our institution, if there is a case of snake bite complaining of weakness, we presume that the incident is cobra bite. So this was the anti-venom that was being given by the patient. It is a polyvalent anti-venom covering the 3 species of cobra. It was observed by the attending physician that the bleeding part temporarily stopped. There was a clot in the bleeding area of the patient in the right limb, lower limb. So when I heard that part, I questioned, because later on I extracted that the patient identified that the snake was viper. So the question is there a cross reaction with the cobra anti-venom to that of the venom of the viper? So the patient was stabilized at the ER and the following ordered. The medication that were given was tetanus toxoid, vitamin K, ceftriaxone, and clindamycin. So patient was then admitted under the internal medicine service. So at day 1, after 4 to 8 hours, pain recur even if there was paracetamol round the clock. And then there was recurrence of bleeding in the bite site. We just continued the pain medication, and then we continue also the vitamin K and then FFP for this patient. So the wound sites are actively bleeding at the ER, with the clotting time and hemolysis are also considered, because this is very common in pit viper pit viper bite incidents. So the persistent bleeding suggests incoagulability according to Lavunas et al. At day 2, because we considered venom-induced consumptive coagulopathy and compartment syndrome, and also by seeing the different parameters of the coagulation parameters like elevated APTT, decreasing platelet count, and the prothrombin time is high, we really consider that the patient have VICC. But then we have no antivenom, pit viper antivenom. We only gave 1 vial of cobra antivenom because we thought that it was cobra. But then when we asked the patient and able to present a picture in the cell phone of a viper snake, he confirmed that it was just like a pit viper. So, but then the question there is, why did it the bleeding is temporarily stopped? So according to Maduwage et al., VICC is the most common and most important hematologic abnormality of the viper bites. Results from activation of clotting pathway by procoagulant toxins in venom. So snake venom components act on factor 5, 10, and prothrombin activators, thrombin-like enzymes, and fibrinogenesis. So we have a patient who has this venom-induced consumptive coagulopathy with this following pathology. We have the snake venom metalloproteinases, which resulted to rupture capillary vessels. And then we have snake venom serine proteases, which alter the hemostatic system and induced edema and pain, which happened to our patient. So this was then the diagnosis of the patient and the findings: thrombocytopenia, prolonged coagulation time, decreased fibrinogen level, increased fibrinogen degradation product levels, decreased coagulation factor levels, and decreased antithrombin 3 levels. So the patient at 2 days, at 72 hours post-exposure, we considered of a compartment syndrome. But then the primary service, which was internal medicine, called the surgery service. The surgery service confirmed that the diagnosis is compartment syndrome. Thus, a premature fasciotomy was done. But then, after the fasciotomy procedures, there was active bleeding. So this was then happened, the severe anemia happened, and because of continuous bleeding, we've given around 5 bags of PAC RBC, 5 units of FP, we gave tranexamic acid, and we gave vitamin K, and the oral ferrosulfate, ascorbic acid, and calcium. So maybe this is really a learning point for all the snake bite cases, especially pit viper, that if we do fasciotomy, we really need to check for the coagulation factors. So severe anemia was corrected starting day 3, and then patient recovered, but then at day 9, patient developed sepsis, and then patient was given piperacillin tazobactam. So this was the basis of the diagnosis of sepsis, which happened to the patient. Then the wound at day 9 appeared like this in the picture. But then patient reacted to the antibiotic. So this was the picture of the skin rash happened to the patient. So the management, the discontinuation of PEPTAS was initiated, and then patient was referred to IM infectious service, and then there was an order from the infectious service to give empiric treatment with vancomycin and meropenem. And this was the result of the blood culture of the patient, the culture sensitivity and growth culture. So hypokalemia also happened to the patient. Then there was also hypoalbuminemia. At day 13, the patient experienced bilateral pleural effusion, and this was the chest X-ray of the patient. So the patient was being managed supportively with a diuretics and then O2 supplementation. Then at day 19, there was anterior tibialis tendon desiccation. So this was now this was the picture of the affected limb. So the diagnosis was anterior tibialis tendon desiccation. So the intervention is the optimization of medical management, wound debridement, blood transfusion, daily high protein diet because anemia recur also at that time. So there was also a negative pressure wound therapy that was given because this creates faster wound granulation, faster epithelialization, reduction of bacterial load, increased tissue oxygenation. And this was ordered by the surgery service. At day 20, we call a multidisciplinary meeting. And then in the multidisciplinary meeting with the family medicine, because of the concerned family members having also problem in terms of understanding the diagnosis of the patient. So it needs a family meeting. The IM, which was the primary service, the surgery, who did the surgical procedure, and the orthopedic, who was also called for the involvement of the bones, and then the rehab medicine. Then it was decided that the patient will be transferred to surgery. And then the ortho suggested that the amputation will be needed, but then patient did not permit and did not agree with the plan of the orthopedics. That's why the general surgery service tried the reverse sural flap procedure. So this was the procedure of the flap. The tissue was then the transplant was done, and this was done by the patient, the cross leg flap, for reconstruction of difficult wounds of lower limb, and this will offer possibility of salvaging the limb. So the patient was admitted and being taken care by surgery service by then. And the patient took around 101 days. And then during that time, through the course of the ward, from 31 days to 101 days, the patient's wound did not improve. That's why the family and the patient was convinced to do and below knee amputation. So the patient was discharged at 113 days. Hospital stay. So the final were very many: necrotizing skin and soft tissue infection, foot right secondary to snake bite with severe pit viper envenomation, electrolyte imbalance, moderate hypokalemia, adverse drug reaction secondary to peptaz, anterior tibialis tendon desiccation secondary to severe pit viper envenomation. We have also pulmonary congestion secondary to transsudative pleural effusion secondary to hypoalbuminemia. Hypoalbuminemia secondary to severe pit viper envenomation. Venom-induced consumptive coagulopathy secondary to severe pit viper envenomation, which was resolved, and then multiple hemorrhagic laceration, legs, feet, bilateral, which was also resolved. Because this patient was admitted during the COVID times, the pandemic, so SARS-CoV-2 negative. Then status post fasciotomy and status post debridement of necrotic tissue, then below knee amputation. So to have also a different perspective, and then to see the outcome of the other, though the first patient is really a severe case, but then we have also a different admissions in a different primary service, which was referred to toxicology to me as a co-managing service, the toxicology unit. But I am not the first service. So this is a 3 cases of pit viper which was admitted in our institution. The first case is 38-year-old male. So this is a brief discussion on it, but then all we did was just a supportive management. So because this patient is a soldier, during the operation in the forest, patient was beaten by the pit viper, as displayed in this slide. It was in a red arrow. So we just managed the patient supportively and gave a tetanus prophylaxis and also the antibiotic and the pain reliever. Then we monitored for coagulation factors and active bleeding, signs of active bleeding. Really a typical manifestation that the swelling of pit viper bites is very severe. The patient was beaten, you can see here, but then the progression of swelling as the time runs, it really ascend until the arm area. Then at this time, the indication is really if the swelling really ascend, the indication to give pit viper anti-venom is really needed, and it's really urgent. But then we have no anti-venom for the pit viper. That's why we manage it supportively. But then, even if we, this is the picture at the 5 days post-exposure, and the internal medicine considered it as a compartment syndrome, I really ordered not to repeat the same mistake, just like the first patient. That's why I did not agree with the planned fasciotomy, because the INR at that time was 2.4. So I just manage it supportively with the vitamin K, and because there is no active bleeding, there's no need to give FFP. Then I gave antibiotic, tetanus prophylaxis, and then if the surgery will fasciotomy, they will really do a intracompartmental pressure measurement, which was not available. Ultrasound to see the diffuse cobblestone pattern, which was not done also. But then, thank God, after 8 days of confinement, the patient improved and was discharged. The next case is a 43-year-old male. So the patient was beaten at the right foot. So patient, while catching a frog, so he was beaten by a green snake. And then when he identified the snake, when I show him the picture of pit viper, he recognized that the agent is really pit viper. It looks like what's in the picture that time. So we managed this supportively also. The edema reached the thigh also, even if the bite is in the foot. So the INR at that time is 4.2 with a percent activity of 48%. So the management was just hydration, even if the urine is really, as you can see, it's dark and it's color blood. But then we just gave patient with tranexamic acid, vitamin K. We ordered for FFP, and I think this was 1 unit was given also. Then we monitor the parameters, coagulation parameters, and other medications were given like pain reliever, antibiotic, tetanus prophylaxis. So the patient, 5 days after confinement, the urine, dark colored urine resolved with the supportive management, and then at 5 days post-exposure, patient was discharged. The last patient, which was newly new case of a pediatric service, referred to toxicology also, a 17-year-old male. While patient was sleeping, the pit viper snake was on his pillow. That's why he was beaten in the lips, then at the head. So in this area and in this area, the patient was beaten by a pit viper because the snake was killed, and we identified it as a pit viper. It was color green, diamond-shaped head. Then it is a Philippine pit viper. So here, as the patient received by our institution the the mouth is really bleeding. That's why we decided, and patient have respiratory distress. We decided to intubate the patient. So the swelling, it was extended in the neck and the chest, and also abdomen. And I have decided that the patient should receive an antivenom, but since we have no antivenom, at 16 hours post-bite, I decided to do a hemoperfusion, and it was done by the good thing the surgery resident did a femoral insertion so that we can do the hemoperfusion with the 2 cartridge at the first session. First cartridge took 2 hours and the second cartridge took 2 hours, so a 4 hours hemoperfusion. So the after 12 hours we did another hemoperfusion, so there was a 4 cycles of hemoperfusion. And thank God there was no bullae and necrosis that was being formed, because most of my experience, if the antivenom cannot be given, the swelling and the necrosis will form a bullae as a sequelae of the viper bite. But then in this patient, after the 4th cycle of hemoperfusion, there was no bullae, and then the ecchymosis resolved. And in the 8 days post-exposure, this was the face of the patient discharged after 11 days of confinement. So that was my experience of pit viper case in our institution at Northern Mindanao Medical Center. So this was the references, and thank you for listening.
Thank you so much, Dr. Richel, for the comprehensive lecture. So we will proceed with the forum Q&A in a short while. And again, if anyone have any questions, please drop them up in the chat box and we will have them answered later. Also, don't leave the seminar yet. We've got a Kahoot session later and we have an exciting prizes to be given to the winner. So now, do we have Dr. Chu and Dr. Harry back inside as well?
Hi.
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 Okay.
Hmm.
All right. Okay. So can we move on to the forum section, doctors?
Okay, sure.
Okay. I think I cannot hear Dr. Chu.
Uh,
Your mic
can you hear
on?
me?
Okay. All
Can
right.
you hear me?
So I'll read the questions. And I noticed that doctors has also replied in the chat box, but I will read them up as well, just for the others who haven't read the chat box. So the first question will go to Dr. Chu. In a resource-limited hospital, RPP is critical for guiding antivenom use. For those patients arriving with tourniquet, what specific clinical steps do you recommend to differentiate between venom-induced swelling and tourniquet-induced edema when calculating the RPP? And when can we consider the calculated RPP to be reliable for decision-making to give antivenom? If Dr. Chu can answer and explain,
Okay,
thank you.
so if it's due to tourniquet causing the edema, most of the time the swelling, it won't extend beyond the tourniquet level lah. But if there's a true snapbite related swelling, then it will start to extend beyond your tourniquet level. So let's say you are bitten over the thumb and you tourniquet at the level at the base of thumb. If it is tourniquet related edema, then it will be stay swelling over the thumb. Then it might show some dusky color depending on how long the tourniquet has been applied. But if it start to extend beyond the wrist, then it's related to the snap bite rather than the tourniquet, because that is much beyond the tourniquet level. So for the calculated RPP reliability for decision making for antivenom, it depends on the increment in RPP progression. So it doesn't mean that you have an RPP at the first hour of 5 cm, then you straight away give. It doesn't mean that. It means that there is an increment. Let's say the first hour is 2 cm, the second hour become 3 cm, then there is an increment. So that is the meaning by this in the national guideline. Okay.
Okay, thank you so much, Dr. Chu. Next question, we'll direct it to Dr. Harry. Given the very real concerns about antivenom impurities and the fear of anaphylaxis, many clinicians might delay administration. My question is, does the delay caused by that clinical fear, waiting to see if the systemic effects progress, result in more mortality than the adverse events of a well-prepared antivenom given promptly?
Yes, thank you. This is an excellent question, and it's captured the heart of the definition syndrome we face daily. And to be clear, systemic inflammation is the severe neurotoxicity or hematotoxicity. So it's the primary driver of the mortality. The anaphylactic fear is valid, especially with we know impurity issues of the local antivenom and others. But my answer is the delay caused by this fear almost certainly result in a more mortality than the adverse event of the antivenom itself. So we can manage the anaphylactic, we can evaluate the sign of anaphylactic. So we prefer give the antivenom beside the delay. Thank you.
Thank you, Doctor. Okay, this next questions will direct it to Dr. Ruchel. Dr. Ruchel, the patient developed an urticarial rash on day 9 while receiving antibiotics. Would you consider this rash to be due to serum sickness from the antivenom, or is it more likely a delayed drug hypersensitivity reaction to the antibiotic? How do you clinically differentiate between the two causes?
Okay. Yes, it might be a serum sickness from the anti-venom that which was the polyvalent cobra anti-venom, because we gave one. But then that was the hypersensitivity reaction happened at around 9th day of admission. We gave the cobra anti-venom at the ER. So because the rash really appeared after few hours of piperacillin tazobactam. So we concluded that the antibiotic caused the hypersensitivity reaction.
Okay. Thank you, Doctor. So back to Dr. Chu. If patient had underlying fluid overload and a long-standing pedal edema, unfortunately, he or she had a snake bite at the leg. So how do we differentiate the swelling between those two by using ultrasound?
If just by ultrasound, it's actually can't differentiate because if you have tried to scan the lower limb edema in heart failure patient, you will see that also it appears as cobblestone. So cobblestone actually just means that there is a edema in the soft tissue. So it doesn't tell you the diagnosis. So like all the other disease, you have to correlate clinically with all the imaging, and not just based on imaging to diagnose. So in these cases, you have to relate clinically because if it's just a purely overload causing edema, the patient won't have any pain. There won't be any tenderness on palpation. So if there is a tenderness to certain level, or even sometimes there is some redness, then you know that it is related to the snake bite rather than the overload edema.
Okay, thank you, Doctor. Okay, the next question will direct it to Dr. Harry. What are the most common diagnostic or management pitfalls you have observed in the initial ED assessment of snake bite cases, and how can we avoid them? Dr. Harry, are you still with us? Okay.
Okay, thank you. Yes, I'm still with you. Okay, I'm sorry, can you repeat the answer question?
Oh, okay. What are the most common diagnostic or management pitfalls you have observed in the initial ED assessment of snakebite cases, and how can we avoid them?
In our appearance, actually, the first is the premature discharge. Usually, patient arrive, has no symptoms, and the evaluation, the first is okay patient, and the patient will be discharged in the ER. Actually, we have to evaluate the WHO 24-hour observation of the rule in the patient, the snakebite evaluation. And the second, usually misinterpreting the tourniquet. So in my case, failing to recognize the edema and discoloration of the tourniquet, so we think this not the cause of venom and lead for the wrong diagnosis or the confusion of diagnostic. And sometimes we local sign, actually the clinician panic with the severe local swelling, maybe is correlated with the systemic risk and or fails the reassert by lack of local sign. So patient can give the treatment by systemic sabu serum antitoxin, and we didn't focus of the neurotoxicity or coagulopathy, just only for the edema in the local sign.
Okay, thank you,
all.
Dr. Harry. So the next one will be to Dr. Chell. Is there any role of hydrocortisone in the management of snake bites?
Yes. If it is clinically indicated, like rashes or inflammation, remember that the steroid will also, though it will worsen bleeding, but it has also a help in the number of platelet. So if there is swelling, inflammation, and rashes, then hydrocortisone is very beneficial, especially if you hear stridor or wheezing, then start steroid.
Okay, thank you
Make
so much.
sure that if you start steroid, make sure that if you start steroid, give antibiotic because it is an immunosuppressant and you have a wound. That's why you give antibiotic if you will start steroid.
Understood. Thank you, Doctor. Okay, the next one will be to Dr. Chu back again. I would like to ask, in your experience and from the literature, is there any typical time window after a bite within which we should be most alert for evolving compartment syndrome?
First of all, because compartment syndrome itself is rare in snake bite, so we won't find any enough data about this. So unfortunately, the literature-wise, there is no exact time frame shown. But just as mentioned by Dr. Harry, for all the snake bite, we have to really follow to the WHO rules. We need to monitor at least 24 hours because some feature may develop late, like coagulopathy, it may develop late. So if we prematurely discharge, there will be severe bleeding into the tissue, and this may lead to increased pressure inside the compartment and even compartment syndrome in the more severe rare cases. So the thing is still we need to monitor properly rather than just follow an exact time frame, because there won't be any data to tell us what is the exact time frame about this. It's not like stroke data that you can activate thrombocall within 3 hours. It's not as such. Thank you.
Okay, understood. Thank you, Doctor. So, and then back to Dr. Harry. As you mentioned before, Sabu lack of coverage for many of the snake bites. Is there any other option apart from Sabu that you use in Indonesia?
Actually, we didn't have any sabu that free available and can get immediately in the case in the ER. So in many cases, we forced to practice supportive care without any specific antidote. So maybe if any development to produce a modern or truly polyvalent antivenom for Indonesia, our maybe Dr. Maha in the department sometimes use some antivenom for the other country people to help. Thank you.
Okay. All right, thank you, Dr. Harry. The next one to Dr. Richel. Is there any specific group of antibiotics for each different kind of snake bite, or we should start all the patient on broad spectrum antibiotics? What about patient with snake bite but mild symptoms not requiring admission? Should they be covered with oral antibiotics as well?
Okay, this is a good. Remember that the microorganism that is present in the oral cavity of a snake, it depends on the location and the diet of the snake. Okay, then the antibiotic, usually in my own experience, I receive 1 to 4 patients, 1 to 4 cases of snake bite per day. So my prescription of antibiotic is based on my experience that if the wound, the bite site, the pain is lasting for 6 hours, or there is erythema that lasted for 6 hours, or there was swelling and a clear punctured wound, trace of punctured wound, I gave antibiotic. regarding empiric therapy, because some of the bacteria is present, like Klebsiella, Pseudomonas, and Morganella morgani. I observed that most of the patient that is that is very resistant to non-broad spectrum antibiotic get a fever, and then the wound is necrosed. That's why when I see severe swelling and necrosis, and then there is fever, I started a broad spectrum antibiotic that covered the Morganella morgani and the Pseudomonas. So I usually started PhiTonS. And also third generation cephalosporin can be also started, but then to cover the Morganella morgani, I usually start PhiTonS.
Okay. All right. Thank you, Dr. The next one is direct to Dr. Harry. In your experience, what practical strategies can ED teams implement to improve community awareness about safe first aid for snake bites and reduce harmful practices like tourniquets or incision before hospital arrival?
Okay, thank you. The question, and based on our experience, the four practical strategies if we perform in the ER is must highly impact. The first is to use the teachable moment. Teachable moment is at discharge, so it's the powerful time to give the patient encourage that if there is any happen with the snake bite, so do not cut, do not suck, do not tourniquet and others, and do immobilization, and as soon as possible go to the hospital. And actually in waiting room and others in the ER and others, can we give the display visual of the how to treat the snake bite in the golden moment, and the report from the in our country using Puskesmas and the community of health clinic. The staff when arrive in our ER, we give the some information, the evaluation of the first treat in the ER, and give the information for the Puskesmas staff or maybe in the community health clinic staff, information about how to treat the snake bite in the first time patient came to the hospital or clinic. And usually that it can be give to the patient or the our team in the emergency and the refer team in the our rural area. That's all. Thank you.
Thank you, Dr. Okay, the second last question is direct to Dr. Ruchel. How is hemoperfusion done?
Okay. Since hemoperfusion is a really new for a pit viper, it's a new intervention because we usually give anti-venom, right? But then it's another alternative intervention if there is no anti-venom. So the reference I have read is the 2023. It's available online. The Jan Teng Ke is the author. The title of the journal is Application of Hemoperfusion in the Treatment of Acute Poisoning. And in this application of hemoperfusion in the treatment of acute poisoning. And in this journal, it says that within 24 hours, if you can do the hemoperfusion, 24 hours from the exposure, the hemoperfusion procedure is effective. After that one, it is case-to-case basis. So I did this one, the hemoperfusion, I did Q12. But then, since it was 16 hours post-exposure already, I maximized it and do the 2 cartridge at the first cycle, so that the hemoperfusion intervention is at a maximum, 2 hours each cartridge.
All right, thank you, Dr. The last one will be to Dr. Harry. Do you have any experience in using inappropriately stored Sabu-2 antivenom? For example, improper cold chain storage or expired Sabu-2 antivenom. How does it perform?
Okay, for your answer to this question directly, I didn't have personal impression knowing administering improperly stored or expired antivenom. The product must be discharged actually, and but I can tell you what happened if this product, why we can use this. The efficacy will be massive loss. The antivenom consists of the specific antibody fragment. When the cold chain is broken, so the protein will be denatured. So the efficacy for this antivenom is very less and increase risk of the adverse event. Usually, the dangerous part for the antivenom is denatured protein can clump or maybe forming aggregates and other highly immunogenic and can cause the anaphylactic. So I suggest you to do not give the improper cold chain or or expired the venom for the patient. Thank you.
Thank you, Doctor. So a huge appreciation to our panelists for the time and effort given during the seminar. We hope that everyone gain new, if not strengthen your knowledge in the management of snakes bite in the future. So now on to the exciting part of the seminar is our Kahoot session. So thank you, doctors. So we will now proceed with the Kahoot session. Okay, we will display a QR code for the participants to join, and we will begin shortly. Thank you, doctors.
Thank you.
Thank you.
Thank you.
Welcome.
Congratulations to our winner, Jamie. Please screenshot your screen and don't forget to email us later to the email that we will share in the chat box. Okay, before we end our seminar, I noticed that Dr. Chu, Dr. Rochella, and also Dr. Harry is still in the chat. To our panelists, is there any final words that you would like to share to our audience? Maybe a short take-home message?
Who will be the first?
Yeah, sure, Doctor.
Okay. Yeah. Oh, yes. So my presentation, it's all about my experience of a pit viper bite management in our institution. So I know that it is not an ideal management because the pit viper envenomation would really need an anti-venom. And then my management in the presentation I presented a while ago is just our experience wherein the number one case is all about premature fasciotomy, which is really need to be considered if you do fasciotomy. So you will check the coagulation and the condition of the patient, and then the intracompartmental pressure should be checked. So the second is all about the management on we usually give, because it's some are have no limited what do you call this one, references but then it were all successful management. So because of experience and limited resources in our setting, and because of experience for 1 to 4 cases of snake bites daily, that management I applied in some of my patients who are really symptomatic, uh, and I appreciated the outcome of that management. So for sure, if there is an envenomation for cobra or viper bites, it's always the gold standard is the management is the anti-venom. And then the supportive management, whatever the clinical manifestation will manifest, and it's a case-to-case basis based on your evaluation of the patient. Thank you so much.
Thank you, Dr. Richel. Is Dr. Chu still here with us?
Yep.
Yeah, hi,
So,
Doctor.
hi. For my part, is still the clinical assessment is very important. So we still follow the guideline. Our audience will be mostly from Malaysia. So actually, we have a Malaysia clinical practice guideline on snakebite management, and the newer edition I think is soon to be released. But the current one, if regarding the assessment and the indication for anti-venom, etc., sorry, my internet. Oh, okay. We just follow our guideline. Inside has a very detail on all the toxins that different family of the like Elapidae, Viperidae, what type of toxins they contain, and also what is the differences, and the difference of antivenom and the dosage is being mentioned inside as well. So surgical intervention wise, we have to depend on case to case basis. It's not similar to all the trauma cases or other animal bites like dog bites, because I'm in Sarawak now. Sarawak rabies over the past few years is still very serious. So compared to other animal bites, snake bite surgical intervention is different because of the different pathophysiology. And so the surgical intervention will have to think properly, especially the serious one like vasectomy, that will be different. Wound debridement wise, we can do whenever there is a necrotic tissue, and once the wound is being already matured, then we can contact our orthopedic colleague to carry out the procedure to debride off the necrotic tissue. And for the antibiotics, we also follow our Malaysia one. And in Malaysia, so far, the literature will mention that the microbes from the oral cavity, because of the snakes, do contain a lot of serious microbes like Pseudomonas, and those will be only sensitive to tazocin, etc. But in Malaysia so far, or just from my practice lah, my personal experience, so far I only use Omentin, just like other animal bites. Of course, if you search online, it will say it is not so sensitive because the oral microbes of snake is different from other animals. Most of the study is actually on the dogs, cats, those big animals. So, but most of the time, if the patient require antibiotic, they will have some wound or even blister. So if there is a blister, you can aspirate it for blood for the CNS. If there is a wound, you can actually just do a swab CNS, then change your antibiotic accordingly. That is my take home point for that. Thank you.
Thank you so much, Doctor. Yeah. Is there anything else you would like to add, Doctor?
No, thanks.
Thank you. Okay, for Dr. Harry. Is Dr. Harry with us?
Okay, thank you the opportunity. My take home message, the first is the embrace the kandaram. So snake bite is the complex puzzle. So we must break the puzzle, and we have some focus. The first, treat the syndrome in my country toxic and mandatory to 24-hour observation to decrease the fatality of the continuing the progress of the snake bite. Know your antivenom limitation. Actually, in our country, the antivenom must be careful too. and then don't underestimate the local effect, and education is the best attitude for.
Dr. Harry?
Yes, I had finished. Thank you.
Okay. Sorry, there was problem with the line.
Sorry.
Okay, thank you so much, Dr. Harry. So that marks the end of our seminar today. I would like to thank
Excuse me,
our...
one,
Yes,
what
Dr.
do you call this
Ruchala?
one? Hi, excuse me. Yes.
Yeah.
Yeah. Can I just say something about our first Philippine Toxinology Congress? Can I promote it?
Sure, no problem
Because
with it.
the Philippine Toxinology Society in the leadership of Dr. PG Tiglao would like to promote the first Philippine Toxinology Congress 2025, which will be on December 3 to 5 to 2025. Will be held in the Puerto Princesa, Palawan. That is a very nice place. That's a paradise. You can inquire through Dr. PJ or just type in Philippine Toxinology Congress 2025. Thank you.
Thank you, Dr. Chell, for the sharing. And that marks the end of our seminar today. I would like to thank our amazing panelists for their time and input, and also thank you. Okay. Thank you again to our main organizers, Universiti Kebangsaan Malaysia, Universitas Brawijaya, and also the University of Philippines, co-organizers, Toxinology, Education, Resources and Development, Wilderness and Austere Medicine Society, Malaysian Society on Toxinology, Remote Envenoming, Consultancy Services, Pusat Racun Negara, and also Malaysia Biodiversity Information System. Not forgetting our generous sponsors, J.A. Nabila and Co-Advocates and Solicitors, Wilderness and Austere Medicine Society, Remote Envenoming Consultancy Services, Malaysian Society on Toxinology, and also Pusat Racun Negara. Before we end the chat, please have a look at our chat box. We did provide links to our previous 2 sessions, and also there are multiple references that we share regarding snake bites management. So a little reminder, please tune in to our seminar next week on the 30th of October. We're coming back online with the team Environmental and Wilderness Medicine with another line of amazing panelists. So before we end, please scan the QR code that will be shared on the screen later for attendance. Thank you, everyone, and have a great day.